Thank you very much, Dr. Nong. And we can see a lot of hours have gone into that presentation, which we much appreciate. I'd like to add, actually just pick up on a couple of points, just to be aware in terms of once you're managing patients post-stroke, this prevention of secondary stroke is very important. And we literally, in the old EML, we literally only had aspirin and the simvastatin as an option. In the newest edition of the EML, they have added rosuvastatin. Actually, they've replaced the simvastatin 40 milligrams with rosuvastatin 10 milligrams. I'm not sure if it's on tender yet and available in our pharmacies. We haven't seen it here yet, but that's useful to look out for. You don't have the interactions with amlodipine. You don't have to take it at night. And the rosuvastatin 10 milligrams is a better option for our post-stroke patients. So we are looking forward to having that available. And then just in terms of TIA, so there are still those that traditionally think of TIA as symptoms less than 24 hours, but we've actually moved away, as you've mentioned, we're from this idea of time to tissue, as they call it. So there are people who might have had a small stroke and has actually recovered most function, but there is actually damage when you do, for example, a scan. So you cannot actually definitively say that it was a TIA unless you've got a scan. So TIA is actually resolved very quickly. A true TIA will usually resolve within a couple of hours. So if you've had somebody who's come in and said, oh, mom had symptoms a week ago, you can obviously do your assessment as Dr. Nong has illustrated to see in terms of future risk, but I would strongly recommend to organize a CT scan, a contrasted CT scan, even if it's not urgent, to start getting some idea of if there's already been a stroke that has actually happened. And then what I'd like to open up for discussion, so we have thrombolytic therapy available with CT scan at both Frere and CMH Hospital. And we have, well, every time we've discussed it, I don't know if somebody can correct me in the room, but we have not thrombolized anybody at CMH in a very long time. And the system is available. So in theory, if somebody shows up and we can do it within that 4.5 hour window, it is possible to whisk them straight through to scan while they're being scanned, to already ask your questions in terms of checking for thrombolysis, for thrombo, the risk for bleeding, and actually get that thrombolytic therapy in within that 4.5 hour window. For this to happen, we need massive input in terms of both the communities and the clinics. So we are at the moment, the challenge is that patients don't seem to realize that you can potentially reverse some strokes if you could get them to a hospital early enough. And so as Dr. Nong said as well, we should be educating all our patients with hypertension, with diabetes, with cardiovascular disease, you know, those ones when you do your cardiovascular risk score and they have a high or very high risk of a stroke, them and their families all need to be, know that FAST assessment. So the FAST assessment is face. So you ask the patient to smile, and if half of the face is drooping, that's the F. The A is you ask both the patient to lift up both arms, and if the one arm drifts down or they can't lift one of the arms, and then the S is for the speech, of course. So if there's any slurred speech or abnormal speech. So those things really need to be drilled into our patients, because even by the time they get to the clinic, it's probably going to be more than the 4.5 hours. In reality, we see most patients days after they've had a stroke. And there's also, of course, the challenges with ambulance services getting to patients quick enough. But it'll be nice to look at some discussion in terms of campaigns we can do in our community. And I'm sure there are the odd patient where we can actually make a massive difference if we can get them to the hospital in time. So this for me is a major equity issue that we have in our area. I'd like to now open the floor for questions or comments. If you're keen to make a comment here at Family Medicine Boardroom, please put up your hand. You can also put up your hands. I think I can see hands. If you are online. Any comments here from the boardroom? Just looking to see. Yes, Nolunto, would you please unmute and go ahead?
Mhm. Good morning, managers, colleagues, specialists. I'm Nolundu Mchwani, I'm NCD manager who is looking at the youth prevention program of the non-communicable disease. Which stroke is one of the complications of, as you have indicated, of hypertension and diabetes. The presentation is very much informative, especially on the prevention side, because what is important is to prevent the occurrence of the condition. Because once it occurs, it's very expensive and it's very difficult to manage. So I'm very glad when you indicated that there's a need that we need to prevent it in our to our communities and so on. I will talk to you on how we can develop maybe an IEC material that will be communicated, that will be shared to our facility so that nurses can understand or can educate our clients and also share that information to our clients so that when they know that they have hypertension or diabetes, they must know the complications, not just knowing, but how to prevent them. I'm very glad joining this session. So it is very informative and is going to assist the population and also the department. Thank you very much. Over.
Thank you very much, Nolunto. And I really want to emphasize, thank you for reminding us, we actually have ways of predicting the risk of a stroke and heart attack in the next 10 years. So within the EML, there's a whole section in terms of risk assessment, and we have different tools we can use, the Framingham being the one, as well as a tool that you can use if you don't have if a BMI-based tool. And we should be routinely screening our patients for stress, risk and managing that risk. And I would really emphasize that is very important, as you say, rather than getting to the point where something has already happened. So thank you very much again for highlighting that. Gomeka, if you would like to unmute and go ahead. And I'm just checking, I see there's questions in the chat as well.
Thanks, Doc. Morning, colleagues. My comment was on the rosuvastatin. It is contracted with McLeod's, and there is also under Chapter 3, there is a table on the indications. So I think people, when they want to refer, there is a table guiding them. When do you use that? Chapter 3 of the adult hospital level. I think we did share the copies because I think it was published in July 2025.
That's correct, yes. So in the new EML, rosuvastatin 10 milligrams is recommended for all secondary prevention patients after stroke.
Yes, that's what I'm saying. There is that table as well to guide the clinicians. Thanks.
The use of that. That's excellent. So what you also, so they look at risk assessment and they will tell you then risk if it's under 5 to 10%, between 10 and 20%, and more than 20%. So when you prescribe a statin and which statins you give. So thank you very much. So please be aware of the new EML that has just been published. I'm just busy now scrolling through the chat. Just give me a second to see if there are questions. Okay, here's a question about toxoplasmosis. How good are you with toxoplasmosis? I see it's about toxoplasmosis antigen values with the IgM that's negative. I am not sure about the answer for that. That's usually something I would discuss with an infectious disease colleague. So this is now a question in terms of toxoplasmosis could be a potential cause for stroke, and if there's a lesion on the brain that looks like it's toxoplasmosis. Generally, many people, if you were to do their toxoplasmosis levels, we all have had toxoplasmosis at some point. So we all would have IgGs that are quite often positive, and then the IgGM is usually negative, and that usually means infection in the past. But I'm not sure what a value of 56 means. I do apologize. Dr. KB, I don't know if you know anything about toxoplasmosis levels. No, unfortunately not. So that will need to be discussed with a specialist. There is a question about fluoxetine in patients post-stroke. So I'm not aware of using fluoxetine as a preventative measure. Generally, fluoxetine only makes sense when somebody actually has depression. I wouldn't routinely give it to somebody who for just purely as a preventative. And what I would recommend is we have our PHQ-2 and our PHQ-9 are very good tools to screen for depression. And what we should be doing is screening for depression every single time we see patients, and then offer the necessary support they need. And then one could decide if one wanted to add antidepressants. But no, I wouldn't routinely use that as a preventative. There's also the clarification regarding specific areas of the brain affected by stroke. So the specific areas in the brain gets a little bit academic, and sometimes it's quite useful if you want to try and find the cause. So if you're not sure, especially in a younger patient, then if you look at the type of neurological deficit they have, and then that can give you an idea also, or which part of the brain might be affected, etc. I'm not sure if that's very relevant in terms of our diagnosis. So in your diagnostic workup for infection with fever and things, I don't know if that question makes sense to you, Dr. Nong. Yeah.
So the fever part from my reading, it was more of something that you look at as like maybe if someone has other conditions that are contributing to the patient's current condition, like as I made an example, those patients with strokes, they are at a higher risk of developing aspiration pneumonia. They are at high risk of having UTIs, especially because some of them will be having those catheters put in them and all.
Thank you very much. There's a question here about having the recordings. So what we tend to do with these recordings, because we find actually the recording of more than an hour is not very useful. Nobody goes and listens to a webinar. So we are going to edit them into shorter tutorials. They are all available on the WUSU Family Medicine and Rural Health YouTube channel. So we upload all of our tutorials on the WUSU Family Medicine and Rural Health YouTube channel. I'll put the name here in the chat as well. And so please go and look there. All of our previous ones are also recorded on there. Shame. And then there's a comment here on the very big challenge.
Can I come in?
Yes,
Sorry,
please,
Madeleine.
Dr. Jakla. Oh, there's hands, yes.
Can you also send it to NMU so that they put it in our package as well, as is unedited?
Yes, so I do send it around to everybody, and yes, they're very welcome to add it to their package as well. Yes, definitely. So there's maybe before I go to the next questions, can we ask Harley M. Jr. to unmute?
Thank you very much. My opinion is that many of our hospitals, especially in the metros, where probably there might be a lessened burden of transport-related issues, but even beyond the metros, is that we do not have stroke teams, as the doctor has actually highlighted, because if we can educate each other from time to time, like as she has actually indicated that a pre-contrast scan actually is adequate to assess the presence of a bleed or not. And actually from that same pre-contrast CT scan, you can identify features of a hyperacute stroke on CT scan, and therefore assist the clinician to be able to say that this stroke took place before 4.5 hours because it's hyperacute. Thirdly, if then, as you have indicated on some of the investigations that the doctor will be performing thereafter, you can then immediately, as you are performing this pre-contrast CT scan, perform what you call it a triple. In other words, there will be a pre-contrast CT scan, an angiography, because we know most of these thrombi, if it's a thrombotic, if it's an ischemic stroke, they come from the neck. I'm not talking about those with arrhythmias, but most of the time the atherosclerosis is taking place in the neck. So you do an angiogram of the neck so that you can be able to identify whether there's a stenosis already there. Thirdly, you do a perfusion-weighted imaging. That will help you to tell you whether it will be safe to antithrombolize or not. So in the presence of that, at times, some of the patients, even when now there's an enthusiasm to antithrombolize, people stop short because these modalities are not being utilized to the fullest inside the hospitals. So that is also increasing the burden of these of strokes that go on to be complicated thereafter. Fourthly, in any situation, if a patient sleeps and wakes up the following day already stroked, you don't know how long it took. An MRI within 10 minutes is adequate to tell you. We call it a flare diffusion mismatch. Quickly, then, if the flare is negative, the diffusion is positive, that tells us that that stroke took place less than 4.5 hours, and therefore you take a decision what to do about it. So I'm just saying, if we can utilize the equipment we have already in the province, we can therefore save those that we can. That's all I'm going to say.
Thank you very much, Doc. Sounds like we've got some radiologists in the room. I think what you've highlighted here, very important, and I really encourage all of our big hospitals to do, is to have a very good, do a little bit of a quality improvement project and set up a system for each hospital. So you're right, some of the biggest centers will have access to all 4 of those modalities, but actually the only thing you really need, or we will use in our settings, is that CT scan, that uncontrasted CT scan. And what you need to be able to have is a setup, and like Dr. Nong has said, you've got a checklist and you have a stroke trolley, and ideally you have a stroke team or who will make part of the team if somebody comes in who's potentially might be a case for thrombolysis, and that you do a lot of your assessment already as you're rolling towards CT scan. In the bigger centers where you have more modalities, it's very good to be aware of those modalities, and then you have to build in a very quick system of how all of those things can happen and in what order, et cetera, to be able to make your time as efficient as possible. This is the kind of thing which you actually have to drill. You almost have to have a plan in your casualty of, exactly from the moment the patient arrives, all the steps to get them into CT as quickly as possible, do your checklist, do your basic examination history, basic bedside investigations to be able to get that medicine on board. And I think, although we don't have neurologists in our hospitals, I do think we are able to, as frontline clinicians, actually put our own teams and QIPs together on this. So thank you very much for that. Dr. John, do you want to unmute and go ahead? Dr. John, you're unmuted, but we can't hear you yet. Sometimes Teams can be a bit annoying. Maybe just play around with your mute button, and at the moment we can't hear you yet. Apologies. I'll go to the chat so long a little bit while you try and see if we can hear you. So there's a comment here about the challenge of EMS, and that for me is a district discussion. So if we want to start doing campaigns for patients to be able to identify when somebody's developing a stroke, there needs to be a plan with the EMS as well in terms of those patients getting to hospital as quickly as possible. There's a question about the difference between simvastatin and atorvastatin. Simvastatin is one of our older cholesterol lowering treatments, and usually when you, for example, if you look in terms of equivalent dosing, your simvastatin 40 milligrams, for example, is equivalent to your atorvastatin 20 milligrams. And we normally usually actually, when you're starting to increase your lipid lowering effect, usually you would move on from simvastatin to atorvastatin. Atorvastatin is one of our newer drugs and also means you don't have to take it at night, and it doesn't have the same interactions as simvastatin does with amlodipines and PIs. So you will see in the old EML, simvastatin was first choice because it's cheap, and then atorvastatin we would use only in scenarios where there was contraindications or interactions. But rosuvastatin, that's another step up, is actually going to be be a better fit, especially for our post-stroke patients. Great. There's a lot of health education here, and I agree. Some patients, at least it gives them the option, if they do have money or they do have transport, that they should at least have the option of being able to get to hospitals. Somebody also mentions here the APC guideline, also very good for assessing risk. And it's got a QR code that's very user-friendly. Thank you very much for pointing that out. So there's lovely tools available for us. There's also a question here on whether to do an LP when SAH is suspected, since the intracranial pressure is likely raised.
So in the standard treatment guidelines, they put doing the LP if the CT scan is not available, then that's when you would see that xanthochromia on your CSF.
Yeah, and in the reality is it's not going to make that much of a difference in diagnosis if you're somewhere where there's not CT scan, because you're definitely not going to thrombolize those patients. I don't know if there's any other comments, Dr. KB, about LPs.
Small bleeding, you may not detect in the CT scan, tiny bleeding.
So Dr. Carl is just mentioning that a tiny bleed might not be noticed on a CT scan. And would you recommend an LP in those scenarios? No, I'm not an A&E.
If the patient is very symptomatic, that can be one option.
Dr. KB?
So if the CT is going to be suspecting subparachnoid, then you need to do a LP.
Okay, so Dr. KB is just saying if the CT is negative and you're suspecting a subarachnoid, he would recommend an LP in that case. It is recommended. Thank you very much. Yes. So there's somebody who's come in now for a history of being on an anticoagulant. So for example, rivaroxaban or warfarin. Now he has a thrombotic stroke and then there's no hemorrhage on CT. Would you be able to thrombolize in those? I'm not sure about the criteria, because you won't have your INR in time.
So there in the thrombolytic checklist, they do say that if a patient has had anticoagulation in the past 24 hours, then it's contraindicated. But if it was a case of a patient who had prophylactic anticoagulation, then that one is not a contraindication.
Thank you very much. So Dr. John, I see you've put your question again there. Dr. Nong, I don't know.
Maybe we can open it to the floor.
To the floor, Dr. KB, there's a question here. If there are specific areas of the brain that can present with fever when affected by a stroke in the absence of other causes of infection. I'm not aware of any, but that might be something I don't know. No, you might have to go and research that further. It's certainly not something we are routinely aware of as stroke as a cause of fever. Specific area.
Speculate, like it's. I can only speculate. It's not something that I actually went and read on, but I mean the hypothalamus is involved in temperature regulation. So perhaps if there was an injury to the hypothalamus, then there would be that issue of a fever.
Thank you. In practice, it's not something that regularly is an issue when we are assessing stroke patients. Is there any comments? I don't see any more hands here online, and we've gone through all the questions on the chat. Any? Yes, Dr. KB, do you want to come forward, please? Please. Otherwise, I have to repeat everything you say.
No, it's just about the TIA.
Yes, it's just Dr. KB is just commenting on the TIA.
And the scoring.
Yes, please, because we're talking about the scoring.
Discriminate between TIA and loans, but it should not be used for that purpose anymore. The 4 or greater score should be used to decide which patient qualified for dual antiplatelet therapy.
Thank you. So Dr. KB is just pointing out that the TIA score that Dr. Nong showed us, this is not, you can't actually make a statement that somebody is low risk or high risk using that score. But what the score is useful for is to identify which patients can get dual therapy, which is then your aspirin plus your antiplatelet plus your clopidogrel. Do we have clopidogrel available here for those purposes? Excellent. So that's the purpose of that particular, and all of them have to go on statins.
Just to remind everyone that every single TIA needs urgent workup.
Yeah. So Okay, thank you. So Dr. KB is just emphasizing that TIAs is a very high risk event, and they all need urgent workup to be able to identify also what the potential causes and the risk of that patient, so we can do some secondary prevention. Great. I don't see any more. Oh, there's one more hand. Ncomeka, do you want to go ahead?
Thanks, Doc. My comment is on the use of clopidogrel longer
Yes.
for the stroke patients. It is actually covered under the tertiary and quaternary for the patients who are allergic to aspirin.
Thank you very much for highlighting that, because that's not actually, I don't know if that's in the EML.
It is an EML under tertiary and
the second, the
quaternary.
hospital one. Yeah, the tertiary one, I hear that. I don't think it's in the
Quaternary.
So
But
that's
there's
quite
that criteria. So that's why we are not advertising it.
But
Because
the
of the
tertiary
criteria.
hospitals, the
Thanks.
tertiary hospitals can use that.
They do, but they don't refer. It's only for patients who are allergic or have got a gastric bleed,
Of aspirin.
allergic to
Okay.
aspirin. Yes.
And again, that's probably a cost
Yes.
issue.
No, it's not that expensive anymore. They've dropped the prices.
Okay, we'll have to give input on that next EML round. Thank you very much, everybody. A real appreciation to Dr. Nong for the amount of work that she's put in to put this presentation together. Let me punt again. The WUSU Family Medicine and Rural Health YouTube channel has all of these presentations and much more. And we really would encourage people to use that. And we wish you all a good Friday. Thank you very much. Dr. Jatla, I don't know if you've got any last words before we close.
No, thank you very much, Madeline. I hope everyone registered for the points as well. Thanks.
Thank you very much.